action.
I'm Sean Lesage from Durango, Colorado, and today I'll be focusing on operating room personnel, circulating nurses, and anybody that basically is part of the surgery in the process. And my goal and objective today is to just enhance the knowledge base on a large external fixator and a delta frame. Because the delta frame is one of the most commonly used procedures in my hospital, especially when we do a lot of like pelon fractures or cyclists and things of that nature. So what makes this system unique, the large external fixator, is that it really is just pretty basic. There's three key components to this system that make it really easy to use, and those three components are these carbon fiber rods, 11 millimeter carbon fiber rods. It's one of the key things we need. We have shank screws, and we also have these Steinman pins. And the Steinman pins actually are going to be for centrally loading on the calcaneus. And so those are the three components. And additionally, we forgot to mention we have clamps. So we have a multitude of different types of clamps. And these clamps can really help take this large external fixator and design specifically to the needed fracture. So if there's an open wound or things of that nature, we can address that with this system. So it's a powerful system, like we mentioned. There's a variety of rods. It's friendly as far as MR. It's non-magnetic materials. Typically, you'll see this is a polytrauma environment. So they may come in and the person could be having like heart problems or cerebral problems. So they'll want to address those first. So what they'll do is they'll take that fracture and they'll stabilize it and try to reduce it as best they can so they can come back and revisit it later. And that's what makes this thing kind of nice. You can also do what's called ligament taxis with this system. And what that is when you have the tendon and the muscles, you'll kind of want to stretch it back into place. They do this a lot in spine procedures also. They'll have a burst fracture. They'll take the shank screws and stretch it out. And it's the same thing like in a long shaft fracture. And so that's kind of powerful. You can get reduction just by utilizing the forces and the compression within the rods. So this is just usually for provisional fixation. And typically what they'll do is they'll come back later and they'll have to maybe put a plate on or something else. Or maybe they keep it on for a month or so. It'll fuse by itself in most instances. If you have good reduction, they'll be happy with that by itself. So what we're going to do today is I have some pictures of an actual surgery where they actually put on a delta frame with a pelon fracture. And I'm going to try to give you some tidbits. Some of you may also have some experience with the X-ray machine. There'll be some images in here to kind of show you what the physician's looking for while he's going along the procedure. So we'll visit that in a second. We have 6 pits. I'll go over the instruments that we're going to use here. So when we start this procedure, in the first place that we're going to be inserting, we're going to insert this centrally threaded Steinman pin. We're going to enter this with the calcaneal tuberosity. And one thing that the physician, I'll come back to this. Calcaneal tuberosity. So one thing that's kind of key for the tech, we know that, and you may or may not know, but heat is kind of dangerous as far as the soft tissue. So what is a nice thing to do is you can take one of those little valves, take some saline, and squeeze it. And as they're getting ready to inject or to screw in that pin, you can just add a little saline to it at the top of this soft tissue protector. And let me just show you how it goes on. You get your drill sleeve. You're going to put your drill sleeve through the soft tissue protector. Take your Steinman pin, and you're going to insert it down there. They'll have it on power. And then as they're getting ready to shoot that, you just add a little saline. That's one nice way to help reduce that heat and hopefully resist that thermal necrosis, which is cell death, which basically what can happen is you can get a lot more scar tissue if you just go in there in that approach. So we got our Steinman pin in. Once you got our Steinman pin in, you're going to have these large combi clamps. These combi clamps are coated blue. Everything in the large frame system is coated blue, so it's kind of easy. If you see anything that's not blue in there, it probably doesn't belong in there. So you'll put these on the sides. And you can see here on this delta frame that I have right here, you got your centrally threaded Steinman pin there. You're going to put your combi clamps on. And they snap on, so that's a nice feature of our system. We have snap on. So what that allows you to do is when you snap it on, you don't have to lock it in place yet. You can kind of provisionally move it around a little bit, make some fine-tuned adjustments, then lock it down. So you'll put one on each side. And when you're putting those on, it's key to have your bolts facing anterior. You don't want to have one like this, and you want to have an anterior. It's just going to make it easier when you go in and you do your final tightening and your adjustments. So that's one key thing is to when you hand the position, you may have to remind him because he's got a lot of things going on in his head. He's trying to reduce his fracture, and so that's one key right there. Okay, so the next step is we're gonna put our shank screws in the tibia. Now, I don't know if any of you guys are familiar with shank screws and what makes these kind of unique versus just a typical standard screw. Anybody have any idea? Well, let me explain it to you. These shank screws have an inner core diameter that is larger than the outer thread diameter. So you're going to have a larger thread on the inner core, and you're going to have a nice constant thread on your outer pattern. So it's going to allow for radial freeloading, which is going to make a better fit for that near and distal cortex. So that's one of the key things with this system. A lot of systems have a tapered effect, which if you have a tapered screw, it can allow for some more movement than you need. And that's the one thing about these frames. You want to have a good combination between rigid and elastic aspects to the frame. If you're too rigid, it's not going to be good for the fusion. If you have too much movement, it's not going to be good for the fusion. So you're trying to find the good combination of both. So that's one of the aspects. So what the surgeon is going to do, if you're thinking from the surgeon's point of view, they're looking for an optimal place to place these shank screws into the tibia. Now there's a bunch of safe zones, and what a safe zone is just what like it sounds. It's going to be an area where they can put this screw in and not have to worry about any tissue or veins or arteries or anything like that, nerves. So this is a safe zone. And on tibia, kind of diagram them out. The more proximal you are, the wider the safe zone you have. It starts at about 220, and as you go more distally, you get down to about 120. So in here between 140 and 120 is typically the safe zone from an anteromedial approach that the physician will insert that shank screw. And you try to avoid the tibial crest. You can see on this demo, someone put it right in the tibial crest here, but you want to be more anteromedially when you place those shank screws. So when they insert those shank screws, I'll get up to the position image. That's the calcaneus. For those that do X-ray, this is what the physician's looking for. This is the position. He's gonna make his incision, and then he's gonna get down to the bone. And there's a demonstration of the safe zones that I talked about. These are some things you'll need. We have shank screws that go by 25, 150, 175, 200. So it'd be good to ask the physician before you get started what shank screw that you would like size. We have the 6-position drill guide. That's this right here. Now these can be screwed on and you can put them in any particular hole. This 6-position drill guide matches up with the 6-position multi-pin clamp. And so really that's what the physician is trying to get, that fixed position. And so it just kind of makes it a lot easier for the procedure. He doesn't have to think a whole lot. He can also just fire, freehand if he wants. That's going to allow a little more flexibility if he wants to do it himself. But for the most part, this is the way to go. You can just have that ready up on the meal stand. So, okay, so he's gonna shoot this in on power, and he may or may not, when he gets down to that far cortex, he may want to actually use the universal drill guide. So you can put this universal T-chuck on, and he might want to just feel to see where he's at, and then also a lot of times they'll feel at the end of the skin just to kind of see how far they are. They can typically feel at, just to make sure, because you don't want any soft tissue disruption if that has gone too far through. So these are some of the items that we recommend that you have ready at this point. And there's the physician actually drilling it in, and you can see right here, this is great for thermal necrosis. You want to make sure this, if you're not doing this now, try to implement this currently as part of your practice or setup, and that'll just help keep it cool. So they recommend that you start with the proximal screw, and then they do the distal shank screw. This is what he's looking at from a lateral perspective. He just wants to make sure that he's in this medial aspect of that cortex. And then you can see how nice this is. You can see that he's got purchase in the far cortex, in the near cortex, and you can almost kind of see just, threads in there. So this is a really good picture. And then he's putting in the final one. Now this is kind of nice. Once, depending on your physician preference, they can usually, they can even use the multi-clamp as their guide. And they can just drop it right down to the multi-clamp, and they can use this. So that's another little technique and tip that you can do. You drop it right down in there, you can fire, versus having one extra step on the nail stand. You'll start to figure that out as the physician does more and more of these cases, but it's a nice little tip that they can do. And here's a great picture having both those shank screws in. And you can see I have both aspects of the cortex. And the next step is adding these carbon fiber rods. When you add these carbon fiber rods, I always recommend you have 3 options up on the nail stand. They come from 100 to 400, and they go by 50 millimeter increments. And typically you're going to have like 350, 300, and maybe like 250. Several options up there. I just have like 2 or 3 of them, the larger ones. And what he's going to be trying to do, as you can see, it's going to kind of create a little bit of a triangle with this based off these clamps. I don't have one of the T-handle wrenches up here, but we have a T-handle wrench, and then we have a ratcheting wrench. The T-handle is really nice. It's cannulated, and you can really crank on it. So that's kind of a nice thing to have. Now you can see right here, fracture. Anybody see that fracture up in that picture right there? You can see how there's that displacement right there. And so he's just trying right now. He's at the point where he's getting the rods in place, and he wants to make sure that he's getting the reduction that he needs. And so there's the T-handle clamp right there, the T-handle. Tighten all the clamps down. And with this system, a lot of times, there's a couple different options as far as reduction, but a lot of times they'll either pull or push on that Steinman pin to help you either compress on that fracture. And right here is attaching that second rod on there. In the compression distraction of the foot. You can see right here, you can kind of vaguely see the rod on this image right here. So really with this system, it's a pretty powerful system. You have several options in the system. Some things I like to cover that you may or may not use. If the physician's not doing a standard delta frame, they may do something a little bit longer of a construct. And we have what are called tube-to-tube clamps. And I'll just hand one of those out to you guys just so you can kind of see what tube-to-tube clamp looks like. And these multi-rings go rod to rod and pin to pin. I don't know if I mentioned it, but it's nice as far as flexibility. One other quick tip for setting up on the nail stand that I failed to mention. You have these little clips on the end. If you know there's a delta frame surgery coming up, you can automatically, right off the bat, you can just add the second arm right on there. So it's just going to save you time instead of waiting for it to get set up. Sometimes the surgeons will just go to the back of the room and do it themselves. So if you have that up on the nail stand, you'll be all set to go. Is there any questions? Pretty powerful system, largest no fixer. You can use it for delta frame bridging and so forth. But, thank you very much.
Blaine, Coach Blaine.
Okay, I liked your opening a lot.
Yeah.
Just kind of bringing everything into focus as to what you wanted to cover and how you wanted to cover it. Briefly went through the parts of the system, the instrumentation. And for me, as a person in your audience, it was a little cumbersome at times, trying to go back and forth between the computer, come back to the instruments, go back to the computer. I'm sure you did a much better job at it than I think I could do, because in my mind it makes it more challenging for you, trying to make sure you have everything lined up so that you can be at your table and then go to your computer and then come back. But you do a great job with it. For me as a viewer though, it was just a little challenging. Your use of parts and pieces was great. I thought that your demo using them was very, very good. And you certainly kept the audience involved, and certainly spend a lot of time pulling pictures together in your PowerPoint presentations, which have a lot of information into it. So I think at the end of the day, what you were trying to get across to your audience, you did very well, and they would have walked out realizing exactly what this frame can do and how to use it. So, and the C-arm pictures were awesome. To be able to see not only how the frame went on, but what it looked like internally and all that. So that was good.
So Blaine brings up a good point, about the use of pictures, and this is something that we always talk about as trainers. You have to be very careful about putting your back towards us and about reading slides, and I'm not accusing you of doing that. When I saw that indication slide, I thought, if he's going to stand there and read these to me, I'm going to kill him, because it's boring, it's hard. You have to kind of be skilled at knowing what's on your slide, being able to, if you're going to use slides, and I don't know how realistic a scenario this is, if these are scrub text, that you have availability of a slide projector and so forth.
Yeah.
But you have to be very skilled at knowing what's on those slides, and so that they can hear you and they can look at it at the same time.
Yeah.
So
we do use, we don't typically, we have it in the morning at some of my hospitals, and we do have like a PowerPoint. We sit down, either the physician or myself come in with a demonstration off via PowerPoint.
yeah.
It just visually just kind of helps you understand.
Absolutely. The more senses you involve in learning, that's why we use that.
Is when I started skipping a few,
Yes.
and it totally set me
And I'm telling you, it turns people off. They go, oh, you're kidding.
I know.
Yeah, whatever.
I should have just pulled a couple of them out of it, because I really didn't need to have them in there.
Right.
You know?
And that's what this is about, practicing. And it's all about making everything relevant and seamless for the audience that you're listening to. Blaine also brought up, your opening was strong when you prepared us for, there's 3 components to this system, and this is what we're going to talk about, and then I'm going to talk to you a little bit about how it's assembled on the patient. That is so powerful, because it says to me, okay, he's thinking through what matters to me, and he's telling me what I can be prepared for, and I'm not going to stand up there and listen to him rambling on and on and on. That's so key to grabbing people's attention and making them want to listen to you when you appear to them to be organized. I'm going to talk about 3 things. There's 3 components. This is what I'm going to share with you during my time. And that just, it makes me perk up and go, okay, good, this guy's a little bit, organized in what he's going to deliver. And you did that very effectively. Anybody else have any comments?
Do you think this would have worked better in the other room?
Over there?
Yeah.
Yeah, oh yeah.
Because we
Really?
we've
Oh,
been
it's
in the
smaller.
other room 2 days.
Yeah.
And then this kind of throws
Yeah,
like
because you're behind it.
a
versus being
curveball.
right
Yeah.
next to it.
Well, but that's his real life too, I mean, the last minute you think you're going to be in a room that you're familiar with in the hospital, and they're going to go, nope, you got to go sit in this closet. Sorry, somebody else is using that. It's just so. And I know that they're looking into the use of the iPads, and if you've got a small group and can gather around and so forth. So I know there's many ways to do it, but it is helpful to see pictures, no doubt.
Well, visually, you can conceptualize a lot easier.
Absolutely.
Like when you touch something, you learn. That you probably heard this
Yep.
before. When you touch something, as you touch and see and feel, it's more likely that you're going to learn and
Right.
grasp it. So.
And the other thing I liked about what you did, and I don't know how much you've heard from the others, but when you can use words like this, the nice system of the nice feature of our system is, or this is a very powerful system because, when you use words like that, descriptive words, think about it. You're much more engaged in what the person's saying than just being, this is this, versus when you use descriptive words, it perks me up. It makes me want to understand what's so powerful about it. What's so nice about it? So.
Yeah, Sean, I think you used some, I like the fact that you provided interesting tidbits and things that'll help the people, your audience, because that to me, how can you help me, make this go smoother for the surgeon? Because bottom line, that's what you're doing. Everybody kind of has a common goal. And to give them little things like that, that's pretty important. And those are the things that, I would remember a lot that, it's going to help them. So I thought that was good.
That's what I was thinking about last night. Like, okay, we went over this yesterday. What can we talk about? A lot of times the physicians, and you guys see it all the time, they'll just fire right in there
I know.
with that stymie again. And it's like, and I'm like, hey, no, I'm not worried about it. But if you can start them off with the right approach on it,
Absolutely.
especially
I
you
think the image you showed of when they were putting the chancelleries into the tibia, where you could actually more clearly see that they had the syringe with the saline to kind of solidify that.
how they're doing it.
Yeah, handing these out so you could see the delta frame. I'd even say pass that model around with
Mhm.
the delta frame already assembled.
Yeah.
For that, so I can look at a picture, but being able to put my hands on it and
That's a good
rotate
point.
it.
But the bad thing about that too is sometimes you don't want to do that while doing a
Well, that's what
presentation,
I-
because next thing I know, I'm paying attention to what's in front of me,
Yeah.
and not even paying attention to what you're doing.
Yeah.
Or I'm paying attention to someone else fumbling with it and watching them and not doing it. So a lot of times when you start handing too much stuff, you did a good job with the clamps. Like, you wanted us to see the clamps on it, so you hand one out over there towards the end.
Yeah.
So we listen to the bulk of all your information. But if you start handing out at the beginning, I'm worried about, okay, that looks pretty cool. When does that come to me? Not worried about what is going through. So
As
that's the opposite of
partially why I didn't do it. Typically, when you do this, in a setting, people are gonna come here and they're gonna touch stuff, feel stuff.
Mhm.
Like, they're gonna
Right.
come up and you're gonna, let them play with it. You preach and then you play. So, but, yeah.
Good. Great job.
Thank you. Appreciate it.
Thank you. Will